prep. Okay, got it. This is what we were given to talk about, which is basically our whole entire job in 1 hour. So we're going to move super fast. So Dalton, please pay attention and stop passing notes. And some of these I'm gonna, most of these I'm gonna hit on with just a one-liner, and some of these I'm not gonna hit on at all. So we'll see what we can do. All right. And I meant to do this with some fun little transitions so you wouldn't see the answers, but whatever. Okay. So we're going to go with this outline right here. Specific pathogens, bacterial, viral, fungal, mycobacterial, and parasitics, special circumstances, perennially acquired infections, vector-borne, immunocompromised, sexually transmitted infections, international adoption, toxin-mediated disease, and then infection control in an international. Okay, bacterial infections. Management, and these were some expounding on that outline that I just gave y'all. These are actual topics from many board, general peds, board prep books that I have that are 2018. Where they are more up to date, like pneumonia, I didn't really want to talk about pneumonia because I don't know what's board testable for you guys. Like what's the most recent stuff they can test on with pneumonia? Because I know we have updated guidelines and treatments based on the evidence.
That
so I was going to let you
what
take pneumonia.
we teach and do in practice might not be the board answer. You see what I'm saying? Like as far as durations and those kind of things, I don't think that we'll probably ask you duration. It'll probably be more what's the most likely organism, what's your first antibiotic choice, that kind of.
Okay, so management of community-acquired pneumonia. It's still the #1 pathogen is strep pneumo, and then we need to worry about Staph aureus too. Clinically, we do that MRSA PCR nasal swab with a good negative predictive value to differentiate between the two. And then management, the boards are always going to be a few years behind. So management, I don't know what they would do.
Yeah, I would think that your answer is going to be either ceftriaxone, right, a third generation cephalosporin, or high dose antihistamines for the strep pneumo, and or Amsterdam if you're trying to get MSSA. So I think that it just kind of depends upon, but community acquired pneumonia, you can treat oral for sure. Typically is your first choice, right? And then if they fail that, then my vote would be go to Optimus. They're not going to ask you about MRSA PCR. They're not going to ask you that, but we know in clinical practice that that's a good.
Yeah, so throughout this whole hour, if we say clinically, blah, 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 that means it's what we do clinically, but not board testable. Management of infant with staph pneumonia, y'all probably have that down. Staph clinically, you can discern on your MRSA nasal swab, PCR swab, and then you can treat that with vancomycin. You can treat that with linezolid. You do not treat that with daptomycin. Do y'all know why? Yes, it is inactivated by surfactant. So dapto is not a good drug for any lung pathology. Findings of a lung abscess. Y'all know that. You see the water level on your x-ray or your CAT scan. You can get a lung abscess from staph, so definitely do clinically that MRSA PCR. You can also get it from a complicated strep pneumonia. So be wary of both of those too.
And anaerobes.
Yes. Oh, yeah. Anaerobes. Thank you.
Yeah. If they're going to ask you on the lung abscess, it's going to be a complicated, right? So the kid's not getting better on community acquired pneumonia. When you do get the chest X-ray, you see the abscess, right? So.
Retropharyngeal abscess. So this is going to be your pain and difficulty with swallowing, you're going to be drooling. That's one of your hot potato voices. On your x-ray, your lateral soft tissue of neck x-ray, you're going to have that prevertebral space is going to be more in depth, larger compared to your adjacent vertebral bodies. Labs aren't not really going to be helpful. You want to treat with IND, and then antibiotics are going to be for group A strep, staph, and anaerobes.
So what's your antibiotic gonna be? Yeah, it's gonna be Unison, or it's gonna be, right, Augmentin, right, Martha?
Clinically, this is not necessarily a surgical emergency, only if it's compromising your airways. And clinically, you can start with antibiotics first before an IND if it's mild to moderate. Peritonsillar abscess. This is going to be pain when you eat and drink and swallow, and you'll have fever. And this is your classic unilateral tonsil swelling displacing your uvula. Labs aren't helpful. This on the board, you treat with IND, and then do antibiotics for group A strep and anaerobes.
Which you can get with one drug, and you don't have to do Augmentin, right? You can actually, remember, amoxicillin has analytic capability, right? You can probably get away with just mox. I don't know what they said. Augmentin fine, but that, I don't think they're going to do that.
Yeah. Oh my goodness, I did not. I'm so sorry. Okay, brain abscess. This will definitely be on your boards. Headache, fever, lethargy. There are risk factors. So if you have a cardiac left-right shunt, if you have chronic otitis, if you have sinusitis, orbital cellulitis, dental infections, trauma, clinically, we see these almost all the time in otherwise healthy African-American boys who are in the ages of 10 to 14. So if you have a kid coming in with an headache, and they have a history of allergies, you want to maybe definitely think about this. Labs are not helpful, but you'll get your CAT scan or your brain image and you'll see it. You want to treat with Vanc, ceftriaxone, and metronidazole because the Vanc for the possible staph. These are usually going to be polymicrobial, but so your sinus bugs, anaerobes. One trivia question for the boards. Neonatal meningitis with Citrobacter is going to be multiple brain abscesses. So they'll most likely have a picture of a neonate with meningitis, and then they'll show you the CAT scan, and they won't tell you Citrobacter, and they'll say, what would you like to treat with? And you will need a gram-negative antibiotic to get that Citrobacter. Multiple abscesses in a neonate. Questions or anything to add? Okay. Osteomyelitis, age-specific pathogens. I broke these down to age-specific, but also pathology-specific. So Staph aureus, all ages, any single age. Group A strep, that's going to be your older elementary school kids. Group B strep, your babies. Strep pneumo, if you have any risk factors, if you don't have a spleen, if you have I'm blinking on
I've been vaccinated.
Thank you. Kingella kingae, 5 years of age and under. Salmonella, that's your classic sickle cell one, but any hemoglobinopathy. E. coli, that's your neonates. But then also remember your baby's born with galactosemia or at risk for E. coli sepsis. So think about that as well. Pseudomonas, that's your classic nail through your shoe into your foot. Bartonella Hensley, this is your classic axial skeleton. So anything vertebral or hip girdle, think about Bartonella. Brucella, your unpasteurized dairy. Actinomyces, your face. And then I have another part coming up with CGD. You will be tested on CGD in your organisms. So no CGD in organisms. So osteo with serratia or aspergillus, that's going to be CGD. And evaluation of infant with suspected septic arthritis of the hip. That was kind of one little topic, but I just kind of expounded on septic arthritis as a hit, not necessary to their infant, but fever, they're going to be presenting with fever, holding that hip in their flex, abducted, externally rotated position, and this hips joints are surgical emergencies. Again, Staph aureus is going to be all ages. Group A strep is the same as osteo. Group B strep and gram negatives are your neonates, salmonellas, your hemoglobinopathy, so all the same as osteo. But then add to that some gonorrhea if you're sexually active for septic arthritis. I forgot, I meant to put Kingella in there too, because you can get arthritis from that. Questions or anything to add? Okay, viruses. My goodness, there's so many more bacteria that we could talk about. Viruses, these are some takeaway subject headings that I found that kind of most commonly came up. So measles, I think measles will definitely be on there as much as we hate it, but remember you're contagious for 1 to 2 days before your symptoms and until 4 days after your rash. It's highly contagious, both droplet and airborne. Most people who are non-immunized are going to get it if they're in contact with them. Management of susceptible children in an outbreak of measles.
And your what she said, non-immunized contacts in your STEM, you're probably going to have somebody who just recently traveled to an endemic area who is in a, unvaccinated or lives in an area where there's an outbreak. Like they're going to give you that, I feel.
Mm-hmm. Or the one in the board prep that I was reading, it was a kid who turned out to have measles, was in your lobby of your office, and who do you need to worry about in your lobby? So read about measles in your red book. The minutia of measles will be on your board, both contacts and how to manage susceptible children in an outbreak, and the vaccine, contraindications to vaccine. We're not going to go into that. But that is a little minutia paragraph in your red book that will be on your boards. So management of kids in an outbreak or people in an outbreak. If you're, you are immune and you need no further stuff. If you're born before 1957 and you have a documented infection or an undocumented titer, or you've had 1 dose of MMR after age 12 months old, and that was in the red book. That don't make sense to me, but whatever. And then also if you're born after that, you have a documented infection or a documented titer or 2 doses of MMR after 12 months old and 1 month apart, but you're not immune. If you're older than 6 months, so if you're not immune based on all of that and you're older than 6 months old, then give your patient the MMR vaccine within 72 hours after exposure. If you can't give it because they're younger than 6 months or they're pregnant, you give an IM dose of immunoglobulin within 6 days after exposure. So much minutia.
And remember too that also if you give the MMR early, it doesn't count.
Yeah.
Right?
Okay.
It doesn't count towards it. Did you say that? I'm sorry.
No, I have that coming up for some reason in a different slide, but no, you're totally right. That should be there, said there too. The same is true with varicella minutia in your red book. I didn't go into this just for sake of time, but read about your varicella contacts and vaccination minutia. Okay, 3-year-old boy presents to the ED following a 2-minute all-over seizure on exam. He has a fever. He continues 1 hour later to have fever and lethargy. CAT scan was normal. LP shows white cells of 52, red cells 0, glucose 45, protein 75. Gram stain shows no organism. The most appropriate next step is diazepam rectally, dexamethasone, you observe phosphonatoin, or acyclovir IV. I'll give you a hint. This is an ID lecture. Acyclovir.
It's acyclovir.
So to walk through, so we're gonna go over HSV encephalitis. So to walk through this one, you don't do diazepam because he's no longer having a seizure. He's just post-ictal. You don't do dexamethasone as a next step. You can consider that if you're concerned about H flu. You don't want to observe because he's not having your typical febrile seizure because he's still having fever and he's still lethargic and he has white count on his LP. You don't give phosphinatone because he's not seizing anymore. So acyclovir is the most appropriate next step while you're figuring out all of this workup. I hate on these boards the most appropriate next step because you'd be doing all of them at the same time. Yeah. Okay. Yeah. Yeah, because you have a leukocyte. So you're not always going to have, so your hemorrhagic tap with your, what's it called? Xanthochromia. That is definitely your classic herpes. But that doesn't, if you don't have it, that doesn't rule it out. Yeah.
And remember that you can, encephalitis, you're more likely going to have the red blood cells in the destruction. Meningitis, you're not necessarily going to have that, right?
But he did have a seizure, so we're kind of in encephalitic territory. So diagnosis of HSV encephalitis. So we worry about HSV in the brain with neonates, of course, with neonatal herpes, and we'll get to that in a minute. And then kids and adults, you can have HSV encephalitis, which is bad. Fever, altered mental status, seizure, any focal neuro findings. Your CSF can be very non-specific, like we just mentioned. The hemorrhagic fluid and the xanthochromia is definitely classic for herpes, but you won't always have it. You can have a pleocytosis, you can have an increased protein, you can even have decreased glucose. Do you know what decreased glucose in the spinal fluid is called? Do you know this? It's a fun word. Hypoglycemia.
Yeah, hypoglycemia.
Your EEG also classically will have your spike and slow wave of your temporal lobe, always classic.
And what is that called?
Ooh, I don't know.
As a name. PLEDS, P-L-E-D-S. You see the word PLEDS and think HSV. Not 100% though, so other things can make PLEDS, but PLEDS is typically
yeah. So that temporal lobe with herpes. But if you don't have it, it's not going to rule it out. So just like the blood in the spinal fluid.
If you just see the word PLEDS, think herpes. I mean, that should be an automatic thing. But if they say EEG shows slow wave with temporal lobe, you're going to count that. Just remember, herpes temporal lobe.
Hey, can you repeat whatever anyone else is saying, just because we can't really hear online?
Yeah. Sorry. So Josh was asking about that in that case vignette, the kid had 0 red blood cells. And so he's like, even with 0 red blood cells, you would consider herpes? And we said, yes. So did y'all hear all that part? Hello.
PLEDS.
Yeah. Thank you.
Okay. And then AK was saying about, so this EEG spike and slow wave of temporal lobe is also called PLEDS. So if you see a mention of PLEDS, then also think about PLEDS, think about herpes. But that absence of that does not rule out herpes. And so absence of any EEG findings does not rule out herpes. So always with herpes encephalitis, you want to start IV acyclovir while you're doing the rest of the workup. So it will stop eating your brain.
PLEDS counts for periodic lateralized epileptiform discharges. And it, in the context of destructive structural lesions of the cortex. It just is okay.
Management of the team with a positive screen for each.
Oh, there's something I want to say. Did you say you absolutely, y'all? This is my pet peeve, and I've said it 5 million times the last week. If you start acyclovir for a kid who has fever and seizures, you have to do the LP. You have to do the LP. A blood HSV PCR does not rule out HSV meningitis or encephalitis. Okay,
Okay.
sorry.
And C. Management of teen with a positive blood screen for herpes. Oh, no. For hepatitis C virus. I saw that come up on one of my board preps for ID, and I was like, that's GI, and I'm not going to talk about it. But I just saw nothing else for Hep A and Hep B. So that's for pediatrics. That's more GI, but I would suggest you probably need to send the RNA PCR to confirm that that screen is positive. And probably some LFTs. Okay, findings of infectious mono. EBV has such a rabbit hole you can go down for any kind of immunocompromised person. I'm not sure it's going to go down that rabbit hole. So infectious mono findings is the topic that I saw in my prep. Fever, fatigue, exudative pharyngitis, lymphadenopathy, hepatosplenomegaly. I feel like you'll know that. Treatment, this was what the question was saying. It gave the case vignette of this teenager with those symptoms. What would you do for treatment? Amoxicillin, dexamethasone, supportive, and some other kind of antibiotic. And the treatment was with mono, it's supportive. So always know with mono, you don't give steroids unless your airway is compromised. So I think only Liz will be giving steroids for mono in this room. Otherwise, there's no evidence base to show that it has any benefit. Same with your spleen. So treatment for mono, regular plain old mono is supportive. You counsel to avoid contact sports until that spleen has clinically gone back down to size. Clinically, maybe not board testable, but AK had a good point to teach about diagnosing for mono. So yeah, you think?
Yeah.
So monospot has very poor sensitivity under age 8. Some people will say under age 12. It also has poor, it's an IgM heterophile antibody. So it also has poor sensitivity early on in the course of your symptoms. So if you just started having symptoms in your teenager, your monospot could be negative. So then there's the titers. The Red Book has a beautiful outline and a table on how to interpret titers. And so the titers are VCA, IgG, IgM, early antigen, and your EBNA. Clinically, nobody in infectious disease world that I know cares about your early antigen. It doesn't really give you much insight into your titer timeline. So we usually don't do the early antigen. The viral capsid antigen, think about it from your viral capsid, and your EBNA is your Epstein-Barr nuclear antigen. Think of your antibodies mounting a response going from outward to in. So your VCA is going to be first, your IgM within a couple of weeks, and then your IgG VCA antibody is going to take over. And then after several months, about 6 to 8 weeks, 2 months in, your EBNA is going to start becoming positive and will be positive for the rest of your life. So these are more sensitive and more specific, definitely in the younger age, and then probably in the earlier of the course, although your M would still be negative, just like the heterophile M.
So what they're gonna do is they're gonna give you a kid who comes in that looks like mono, and it's gonna be IgG negative and IgG positive. They're going to want you to interpret whether it is more of a recent infection with mono or a past infection. It's all about the EBNA. Remember, you just said it takes at least 6 to 8 weeks for the EBNA to be positive, right? So in that case, on her vignette, EBNA is negative, and that is currently mono. Does that make sense? Okay.
Can you repeat that in the microphone? We couldn't get into that.
Where is the
Where's the
microphone?
microphone?
She's like standing right next
I'm
to
standing
me.
right next.
Oh,
I don't know, but
there.
we hear Dr. Weiner clear and not Dr.
I hate these things because okay, so they're gonna give you, can you hear me now?
Yes, thank you.
Okay, so they're gonna give you a kid that's IgM negative and IgG positive with the symptoms of mono, and then they're gonna ask you if this is a past infection or a current infection, and what's gonna decide that is whether or not you have a positive EBNA. Remember, it takes EBNA at least 6 to 8 weeks to be formed. So if the EBNA is negative and the IgG is positive, then that is a recent or current mono infection.
Just for the record, this is the first time anyone's ever told me they can hear me and not AK. Okay. 16-year-old previously healthy kid with 2 weeks of intermittent fever, headache, malaise. Oh my gosh. Fatigue, myalgias, worsening dry cough. Recently went to several caves while hiking in a forest in Ohio. Labs show very non-specific things. Chest x-ray has patchy opacities and hilar lymphadenopathy. Most likely pathogen is Aspergillus, Coccidia, Histo, Rhizopus spore. Histo, okay.
Ding, ding, ding.
So Aspergillus, we're gonna go over that, all of that. So Aspergillus. Okay, so these were the fungal hits that came up. We'll talk about this. So Aspergillus is mostly going to be your old decaying vegetation and your construction junk. Most of the time for your immunocompetent people, it's just mostly hypersensitivity reaction, a little bit of annoying cough, and it's not going to usually do disseminated infection, which is kind of what this person has because of the fever, malaise, and myalgias. It will only do disseminated stuff usually if you're immunocompromised. Coccidio is going to be just that story, but in the Southwest. So Coccidio is just like Histo, but Southwest region. Histo is going to be your Ohio, your Missouri, and your Mississippi River valleys. Rhizopus is only just immunocompromised stuff, and Sporothrix is going to be your thorns and it's usually lymphocutaneous. Okay, so fungal infections. Here are some topic hits that came up for me. Treatment of oral candidiasis. I don't want to go into that. Nystatin, fluconazole, gentian violent, whatever. Predisposing factors to candidiasis. On the PrEP, it said repeated antibiotic use. I did not look over any of my spellings. I'm so OCD about that. Repeated antibiotic use, catheters, multiple surgeries in your butt and your belly, cancer, steroids, severe burns. Remember that? Transplant. Yes, your immunocompromised states with your T cell stuff like HIV, and then your neonates. Anything to add about Candida? Symptoms of coccidia, we just said, it's histo, usually pulmonary, just like histo, but your patient will be from the Southwest. Aspergillus, we just talked about that. Histo, we just talked about that. Sporotrichosis, we just talked about that. Questions or anything to add?
No, but bring out the bats and the chickens with histo, and that truly is
Yep.
it. So that kid was not only in Ohio, but was in a cave.
Yep.
And what a cave had. Bats. I don't know.
We had the cutest, teeniest, tiniest little bat on our screen last night. He was so cute. He was like that big. We thought he was a little tree frog at first. He was so cute. Sorry. Okay. Mycobacterial infections. I didn't write anything on here because I didn't get to it, but these are some topics that came up. Management of atypical mycobacterial adenitis. I think Dr. Birch just gave y'all.
No, next week.
Oh, sorry. She's giving next week a lymph node talk. So, and it will include atypical mycobacterial adenitis. And so remember this on your boards, very testable and clinical, is a violaceous, nasty, gross cervical lymph node in a toddler. And that's going to be an atypical mycobacterium. So non-TB. Treatment for that is complete surgical excision. Complete surgical excision. Okay. Major clinical manifestations of NTB in immunocompromised child. Most of the time, this is going to be MAC with your pulmonary stuff, but you can have disseminated non-TB mycobacteria in your bones, in your joints, in your lungs, in your belly.
Liver and spleen.
in your liver and spleen. No other major clinical manifestations of TB. So other things tuberculosis can do, it can do lymphadenitis, pulmonology, of course, arthritis, and pyuria. Oh, and I skipped over findings of TB meningitis. Who here in the room has seen TB meningitis? That SHIT will F your kid up. That is, so yeah, so that's bad. So it's usually always think of TB meningitis in your kid, and they came into the PICU, coming into you. Where are you going to do fellowship? Oh, okay, so pay attention. So it is a subacute meningitis. So your kid will be throwing up and headache for a couple of weeks. It has stages, stage 1, 2, 3. It has horrible morbidity based on the stage, and only stage 1 is fine, and the others are horrible. It classically presents with a bibasilar meningitis. You can have hydrocephalus. Steroids are definitely indicated for that. And then your TB treatment, which your 4-drug TB treatment. And I think that this is not board testable, but clinically, and I can't remember, but I think ethambutol has less blood-brain barrier penetration than ethionamide. I think it's ethionamide, is your E and you're right. But you do want to do steroids. And this classically will be in your toddlers. If you do have a kid with TB who is age 1, sometimes people even say age 2, and you're working them, they have known TB, you do need to do the LP because it can be so subacute and non-specific in your symptoms, and you can miss it. Management of newborn whose mom has active TB. Oh, I didn't go there. In a family, I did bad on teaching y'all infection control, but it's just minutia in your red book that will be testable. So pay attention to these topics and look them up. All right, reviewing a case for M&M where an infant died. An infant born term to G1P1 mom, binormal vaginal delivery. Mom was group B strep negative, APGARs were 9 and 10, but on day 7, the baby developed fever, brought into the ER, found to be in shock, required intubation. Exam showed icterus, hepatosplenomegaly, no skin lesions, LP could not be done. Labs were white count of 2, hemoglobin 7, platelets were low. PT and PTT were out of whack, AST 3000, ALT 400, total bilirubin 4. X-ray with diffuse interstitial infiltrates bilaterally. Most likely cause of this patient's death is adeno, E. coli, group B strep, herpes, and listeria. I'll give you a hint. This is an ID lecture. No, I'm just kidding. They're all pathogens.
The nastiest looking infection.
Adeno can definitely make your patient this sick, but the key is most likely. So herpes. So anytime a baby, a neonate, comes in a DIC, think of HSV, herpes. So adeno can definitely do this, but not as likely as herpes. E. coli and group B strep, per the question explanation, can also make your kid definitely this sick, but it's not going to make your LFTs that high, and it's not going to do the chest x-ray, the pneumonitis that much. In all, clinically, you're still going to be doing a blood culture, and you're still going to be doing antibiotics for this kid for group B strep and E. coli, right? But do not forget about herpes, because that will do this crazy LFTs like that, but DIC is big with herpes in a neonate.
So if this was without the DIC, like those two moments.
It also said,
Basically just, sorry, yeah,
And interstitial infiltrates bilaterally. That's what gives you the virus.
okay, that makes sense. Okay, so
Right,
All
the
three of
virus
those
is called
qualify.
pneumonitis.
All three of those qualify.
Because they can't hear me.
So
Yeah,
Dalton,
basically it was a different question, the 7-day-old.
yeah, I was wondering the same too. So Dalton was asking a question that turned out not to be a good question, so I'm not going to repeat it.
Okay, I still do it.
Dalton was asking without the LFTs and without the pneumonitis
Yeah, like they're just saying, day 7.
on day of life, on day of life 7,
Yeah,
what's the
is
most
that
common
gonna
cause
be
of set?
EBS, then E. coli? Right? It's
I-
not coli.
Correct, currently,
Yeah.
that's the way it is.
So
But
Dalton,
they're like neck and neck.
yeah, so Dalton was asking between group B strep E. coli, and then I'm going to throw in listeria. If it was just this bacterial sepsis in this neonate, which would be the most likely cause, then we would probably say group B strep. Even if mom's test is negative. I have had a kid, so the thing about the group B strep maternal testing, it's great positive predictive value. It has decreased group B strep mortality greatly, but it's just a one snapshot on that one point in time.
And at 7 days, this is late onset, right? So it doesn't have anything to do.
Okay, so Harry,
I mean, it does for early onset, of course, but not for the late onset. But they're neck and neck, literally, they are neck and neck.
for perinatally acquired infections, some of the topics, I don't know what, I'm not going to talk about assessment of infection risk in children with HIV. I'm not sure what that, I meant to take that one off. So congenital CMV, congenital syphilis, and neonatal herpes. So let's just go on neonatal herpes since we were just talking about that. We've got SEM disease, localized CNS disease, and disseminated disease. Those are our 3 categories, but it's thought to work on a spectrum of those, which is why you can have a negative blood PCR and still have positive CNS disease. Okay. So for disseminated disease, it can commonly do liver, lungs, adrenal glands, still go to your brain, and then also the DIC is the liver. Most moms, I always say this whenever I used to go to morning report, most moms in babies who have neonatal herpes, 80% of the time, mom will have no sign, symptom, or history of herpes. So whenever the med student in morning report is like, does mom have a history of herpes? And Stallworth is like, no. Yeah, it's still nice to ask. It does not rule out neonatal herpes. Babies with neonatal herpes are going to present between day of life 5 to 10 on this board prep explanation. Clinically, anywhere from that and up until like day 15, day 20. Several of them can have no skin lesions, even in disseminated disease. You want to do the workup, the full workup is the PCR of your spinal fluid, of your blood, of your lesion, and then do your surface cultures. And always, always, always treat with acyclovir, that is IV. 14 days for SEM, 21 days for the rest. Questions?
Just because you have a positive HSV PCR in the blood doesn't mean it's disseminated
Yeah, so
clinically.
yeah, so clinically not board testable. We still don't know what to do with the blood PCR. It's indicated to do it as part of your neonatal herpes workup, but we don't know what to do with it yet. You don't have to, if it's positive, you don't have to repeat it at the end of treatment. If that is the only, if it's positive, that is not indicative of disseminated disease. Disseminated disease, you need multi-organ involvement. You can have it with just SEM disease. You can have it, and that's the only thing that can come back positive. And how long to treat that is up for debate.
Up to us.
Questions about what I just said? Okay. Congenital CMV. I could do a whole hour on that. Oh my gosh, where to start? So congenital CMV can give you classically board preppable your periventricular calcifications, some migratory problems with your brain, some hydrocephalus. It can do chorioretinitis. It can do hearing loss, and the hearing loss is progressive. So the only thing that can progress with congenital CMV is the hearing loss. As opposed to congenital toxo, your brain damage can progress if it's not treated. Make sense? Okay, so hearing loss can progress. Nice hearing loss. It can do a pneumonitis. It can do direct hyperbilirubinemia and a colitis, and then your blueberry muffin rash with your thrombocytopenia and your hepatosplenomegaly. We treat with PO valganciclovir for 6 months. You test for it. Ooh, I don't know. This should be board testable, but definitely clinically. Don't ever test with titers for congenital CMV.
God, please don't do that.
IgM can have false positives. IgG is indicative of moms and won't tell you anything about your baby. The way you diagnose congenital CMV is within the first 4 to 6 weeks of life, do a urine PCR because you will be shedding the crap out of your urine with that virus. So that's a high target source. So urine PCR, you can do a saliva PCR. Blood PCR has poor sensitivity. If it's positive, that's great. But if it's negative, that does not rule out congenital CMV. Questions? I just did an hour-long talk in 3 minutes.
And the difference between congenital CMV and congenital rubella on your test question is going to be what? What are they going to give you with congenital rubella? And the cataract. So they're going to give you a heart lesion with congenital rubella, but they can look exactly almost alike. And then instead of chorioretinitis, hopefully you can hear me, it's cataract, but can be the other two.
Okay, congenital syphilis
Hot mess.
is a hot mess, and I don't know where to start for that. I could not find any board prep questions for this, surprisingly.
I would say that the most important things are that if you have a mom who has syphilis during this pregnancy, you always have to do something on baby. You need to compare the same test that you have on mom on baby. So if they do a VDRL on mom, then the answer is you're going to order the VDRL on baby. Does that make sense? Now, we always do RPRs here, but it just has to be the same non-treponema antibody testing that is with mom, so you can compare them. Can't compare a VDRL to an RPR. Make sense? Okay. Also remember, and people get this wrong all the time, right? It's a 4-fold titer change, which is 2 dilutions. 1 dilution is a 2-fold titer change, okay?
Yeah.
So a non-reactive compared to a 1 to 4 is positive, right? So you went from non-reactive, or I'm sorry, 1 to 2. So you go non-reactive to 1 to 1, and then 1 to 1 to 1 to 2 is 2 dilutions, but a 4-fold titer. Does that make sense? Okay. People confuse that all the time, all right? So no, and most people do. I'm telling you, it's very confusing. And if you look in the red book, it'll specifically tell you examples of that. But you're using that when you're comparing mom to babies, non-treponemal antibody test. Okay, so if babies is 4-fold higher than moms, then that is syphilis, congenital syphilis, and you need to treat. So if mom was 1 to 1, then you need to have no. So that's the thing. So 1 to 1 then goes to 1 to 2, then 1 to 2 goes to 1 to 4.
Oh, and that's 4.
Yes, even though you only go twice in the
And
numbers.
1 to higher.
Mhm.
Right, right.
Correct.
There we go.
That is correct. So 2 changes to your titers is a 4-fold titer change. Does that make sense? 2 jumps is a 4-fold titer change. You don't have to do 4 jumps. It's not. Okay.
Can I ask a question on this?
Sure.
Can you talk about background questions on like how long do you wait to test baby for HIV or can you talk about this?
Oh, yeah.
That's good.
Yeah, and so, and I was thinking about the, right when you said that, I was thinking about testing for HIV.
Wait,
Okay.
but let's finish congenital syphilis real quick, so just so you remember. The other test question you might get is, what do you order on the CSF? What do you order on the CSF?
Oh,
Huh? So you order a VDRL. So you do your normal indices, but you also do a VDRL, okay? And remember that even if the VDRL is positive, it does not change your duration of treatment. If you're gonna treat like congenital syphilis, it's 10 days IV. And whether or not your PCR or the VDRL is positive on the CSF does not change that 10 days. People get that confused all the time too, because they call me and say, the VDRL is positive, so do we need to treat longer? No, you don't. It's not like HSV. If it's positive, you treat longer. What you do is repeat the LP at 6 months of age. Okay? Okay, I'm done.
Okay, testing babies for HIV. This is a very board testable question. So the classic board question will be, you have a 6-month-old comes in for failure to thrive to your office, and you're concerned about HIV, which test do you send off? A, viral culture, B, HIV antibodies, C, virologic testing with the PCR. Viral culture is never an option. We don't do that anymore, forever. Antibody is going to be maternal antibody up until age 18 months old. So maternal antibody is going to persist in baby for both HIV and nicely for Hep C up until age 18 months. And so to confirm infection in the baby on the boards, you want to do a PCR. Clinically speaking, you could do the rapid HIV on the baby. And if it's negative, you're done. And because you'll get that back much faster. If it's positive, that's mom's antibodies. Now you need to do the PCR on the baby to confirm baby infection. Does that make sense? Okay. But on the boards, it wants you to do the PCR straight up.
And it doesn't matter if it's RNA or DNA, even though we do DNA here. You just want the PCR.
Yeah. So that's for HIV. For hepatitis C in a neonate, I don't know how they would phrase that because it's a little wishy-washy in the Red Book as well. You would definitely send off at age 18 months a hepatitis C antibody. 18, because maternal hepatitis C antibodies can persist in the baby until 18 months, just like HPV.
And so I think that really, because it's kind of questionable, because we can do PCRs at 2 months, but that doesn't rule it out. The answer on the test is you do the antibody at 18 months for Hep C.
Clinically, because we do get this question a lot. The Red Book will say, and I will say, some people would want to draw testing earlier for hepatitis C in the baby, so you could do the RNA PCR in the baby. Clinically speaking, if it's negative, you're still going to do that antibody test at 18 months. If it's positive, most of the time, the baby body is going to clear itself of that virus, and so you don't have to worry about it. Also, we don't have any medication indicated for infant age to do anything about it anyway. So if it's positive, what are you going to do about it? Does it cause more worry in the parent? It's like a whole conversation. That makes sense? So I don't know if that will be on there. So if mom has HIV per the Red Book, when do you test baby is the question for HIV exposure. The Red Book will say a plus or minus test at birth. We always do it at birth because we have our couple of scenarios that we do worry about, and we don't want to pick and choose those. We just want to test them all. So Red Book will say plus or minus test at birth. And then you test at 2 weeks-ish, like 2 to 4 weeks. And then at 1 to 2 months, and then at a 4-month test. And then a plus or minus test for antibodies at age 18 months. We do that, but not all people do. So I don't know how, I'm not sure how that they can test you on that.
I just always remember 2 weeks, 1 month, 4 months.
Yeah.
And then the other thing about these that you might get asked about is technically still to this day, Dr. Widener, it is contraindicated to breastfeed and then if mom is HIV positive. And it is not contraindicated for mom to allow to breastfeed her baby with hepatitis C.
Yeah, that's a good nursery question that
Okay.
we get to. Hepatitis C, you can breastfeed.
HIV, don't breastfeed, even though that is very debatable these days if mom is undetected.
Oh my gosh.
Don't call DSS on mom either.
We have so many. We have so
I
many
know, and we
slides.
have 5 minutes.
Okay. Vector-borne infections. Findings of Lyme disease. Lyme will not kill you. It's a rash and it's sore, and it's sore joints. Bell's palsy. Also think of Lyme disease.
Need to be in a Lyme endemic area. Clinical diagnosis.
Treatment for Lyme is either amoxicillin or doxycycline. Doxycycline you can do if you're over age 8. Otherwise, if you're under age 8 or if you're pregnant, then amoxicillin because it's not going to kill you. Rocky Mountain spotted fever will kill you, and the drug of choice always is doxycycline, regardless if you're pregnant or if you're a young person under age 8. The T staining side effect is duration dependent. And so the duration you need for Rocky Mountain spotted fever is like that. It's just like 7 days-ish. And so that's not going to stain your teeth. Got it? Symptoms, differential diagnosis and treatment of Rocky Mountain spotted fever is super fun. It's a vasculitis. The pathogen is going to bust open the endothelial membrane, act as a vasculitis, so it can cause aseptic meningitis. It can do an ARDS picture. It can do acute kidney injury. It can do, did I say aseptic meningitis? Yeah. Myalgias.
In my mind, it looks like Neisseria meningitidis,
Ooh,
sepsis.
Yeah.
Anytime you want to treat somebody for Neisseria and it's appropriate, you need to treat for Rocky Mount and vice versa. And on the test, you're going to have low sodium, LFTs, and maybe some low white count and thrombocytopenia. And you're definitely going to have the rash. Okay. Clinically, the rash, and then we'll tell you this, although, I'm sorry, on the test, the rash, starts at the wrist and the ankles and it moves in, blah, 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 yada, yada. But in real life, the rash can start anyway. And it can look like maculopapular before it turns petechial and purple.
treatment is with doxy. If you're treating and starting doxy, that's going to be pneumonic and you'll get, no, that's not the word, whatever. That's going to be diagnostic and your patient will get better within 24, 48 hours of starting the doxy. If you're starting doxy for Rocky Mountain spotted fever, no, if ever you're sending titers, which is your diagnosis, it's going to take a week to get back. So always start doxy if you're sending off antibody
And they're
titers.
negative. The first ones are probably going to be negative, y'all. Right? This is a clinical diagnosis, not based upon titers. The same thing with Lyme disease. It's not based on titers. It's a clinical diagnosis. What you're going to see is acute and convalescent. So 2 weeks later, 3 weeks later, those titers will then be positive. That's how you make the final diagnosis.
Immunocompromised host, sorry, cancer people, I got nothing for you on here. PCP, fever, dry cough, hypoxemia. CGD, I did not do any immunodeficiency states because that apparently was not me, but on all your immunodeficiencies, CGD will be on your boards and you better know your pathogens for CGD. That will be on your boards, that list right there. Staph, Serratia, Aspergillus, Nocardia, and Pseudomonas. Okay. STIs, I didn't want to do gonorrhea because I don't know what's testable since it's just some changed. I didn't feel like talking about those. Y'all know that stuff anyway. International adoptees, You want to screen for Hep B, Hep C, syphilis, HIV. You want to do your CBC, your stool OMP, GRD, and crypto, TB, or an interferon gamma release assay. If they're in an endemic area for Trypanosome cruzi, do that. If they have eosinophilia and a negative OMP, look for Toxocara, Strongyloides, and schistosoma if they're in a schistosoma area. Toxin-mediated disease, I didn't write anything on here because I thought we're gonna have time just to talk about it, but symptoms of brown recluse spider bite, just necrosis, think of that. Symptoms of strep, necrotizing fasciitis. Fasciitis, neck fascia is gonna be pain outside of what you should see on your exam, and that's a surgical emergency. Recognition of toxic shock, there's criteria for that, but just remember hypotension and multi-organ stuff. And then also remember your skin is part of that. So erythroderma rash, the sunburn rash, and other multi-organs. Staph scalded skin, your kid's gonna be super fussy and it's gonna have a positive Nikolsky sign. And then I feel like y'all know staph scalded skin.
I will tell you, clinical practice and what they're going to test are going to be different here. So nowadays we try to do linezolid, right? For, remember the Eagle effect that we talked about, all that kind of stuff, right? Which is toxin mediated. Probably not going to give you linezolid on there. They're probably still going to give you the clindamycin. So you add the clindamycin in addition to your traditional therapy. Now we know not to do that though, right? It depends on your susceptibility profile, but group A strep, which is also part of TSS, clindamycin is not a good drug for group A strep, right? So that's why linezolid is going to be better. Same thing for MSSA here. Depends on where you really practice, though, what your antibiogram is going to tell you.
All right, a 16-year-old works at a zoo. His mom's concerned about getting rabies. Sorry for all these typos. If he were to be bitten by an animal. Animal bite most likely to require rabies prophylaxis is a bite from a chipmunk, rabbit, rat, squirrel, woodchuck. No,
No.
rat is actually not a typo. Answer is E, woodchuck. All right, everybody write this down, especially Heather. Write down the words Maine runner rabies. Google that and read the first story that comes up. It's one of the best stories ever. Oh my gosh. Don't Google it right now, Dalton. Okay, so for rabies, oh shoot. There you go, rabies. So management, you're gonna need your rabies prophylaxis, which is immunoglobulin and your vaccine from a bite from a raccoon, skunk, fox, coyotes, bats, beavers, opossums, groundhogs, which are the same as woodchucks I just learned, wolves, bears, cats, dogs, and ferrets. You do not need prophylaxis if it's a small rodent or a lagomorph. Dalton, what's a lagomorph?
Mouse.
It's a rabbit, your rabbit family. A mouse is a rabbit. So from small rodents or your rabbit family. You do need to do prophylaxis for any bat that is found in a sleeping child's bedroom or any person's bedroom or an unattended child, because the bat can have teeny tiny little teeth. And cases of rabies have been described where the child died and the only exposure was retrospectively, oh yeah, I guess there was a bat in the bedroom. I do remember seeing that because there was no indication of any bat bite or mucous membrane involvement and the kid didn't wake up. Prophylactic antimicrobial therapy and household contact from infectious diseases. This is also Red Book minutia, so pay attention to meningitis from Neisseria, strep pneumo, and H flu, and who do you prophylax and who do you not prophylax. Bacteriology and management of wounds from dog and cat bites. I feel like I teach this all the time. What do you get from a human bite? Yes, Eikenella. What do you get from a dog and cat bite? Pasteurella.
And what does not cover Eikenella? Clindamycin. Do not use it.
So Augmentin.
I have had that as a question.
Oh, you did?
Mhm.
So Augmentin or Unison is perfect prophylaxis and treatment for any bites because it gets the gram negatives, including Eikenella and Pasteurella. It gets your skin flora and it gets the anaerobes and other gram negatives from people's mouths and animals' mouths. Okay. Parasitic infections, we're
I think
over.
we're over.
Yeah, we're over time. So here's parasitic infections and some common parasites that are testable. International travel, things that I could not find any board prep questions specifically, but international travel was a topic. So these are thought were just kind of important. I like the meningitis belt trivia. It's fun. Yes. Questions about any of that? Oh my gosh, that was so much and so
Yeah.
fast, and I'm so sorry.
Thank you. Could you please send these out to the residents?
For $20, Venmo to.
It's worth it. It's worth it.
I doubt it. Mm-mm. I don't think that they could test that
Yeah.
because it's just changed, honestly.
Josh was just asking a question about what would be testable for treatment of gonorrhea on the boards, and we really just don't know.
Yeah, that's what I'm saying. I don't think that it'll be testable. However, if there is something on there, go to the old. No, I do not think so. But regardless, I think you would go with the old treatment, even though, because it's, yeah. But I'm like Rob, I think that they will take out those questions.
Right? It's insane. Yes. You don't F with a Maina. Those people are wicked.
Oh, by the way, though,
Cool.
if you could ever get the bat, keep it and put it in your refrigerator. And as long as it's in your local DHEC, whatever, wherever you go, can do a necropsy and find out if it was rabies or not. And then you don't have to do PEP. It's not rabies. No, totally, no. You don't, because it's gotta be fresh.
So how do you suggest getting it? Open the door?
You do like white and trap it on your head.
Yeah,
And
but
the
they,
nervous
that
trap
was,
it.
they
Yeah.
eventually-
Get a broom and bat it.
Yeah,
Bat it with a broom.
I put it,
You're saying this like you do a
yeah,
lot.
no, I'm telling you. Stuff I have all the time. I get phone calls. Well, Johnny ended up blowing it up with a shotgun. Well, shit, you got that. Sorry.
Or drowning it.
Seriously, I get these questions all the
But I
time.
mean, how do you get it alive? Right, but I mean, the whole time you're trying not to get wet and get rabies. Right, like, there's risk.
How are you gonna kill it?
I don't know, I don't know, I'm asking
Take
practically what.
I'm like, be a man and take a broom and like, no, actually not. So that is very
His
accurate.
best friend's family.
Yeah, no, seriously. Insurance does not, most of the time, pay for it.
It's like $60,000.
No, it's not that much, but it's like up to 10.
600.
No, it's like up to 10. And insurance typically does not cover it.
So, you don't have a choice, because then.
But I will tell you that rabies is almost 100% preventable, but it is also. And don't forget to give a tetanus shot. With your bite.
Okay, I guess anybody else on here got questions?
I thought they were holding it.
I think so too.